everybody. Welcome to our morning session on preventive cardiology. We have three distinguished speakers for this morning. First off is Dr. Raymond Oliva to talk on statin intolerance, clinical trial evidence, and clinical practice guidelines. Next, we will have Dr. Lourdes Santos to talk on non-statin therapy for LDL and non-HDL lowering therapy, which patient, which agent. And last but not the least, we have Dr. Elmer Jasper Llanes to talk on risk factor counting alone identifies statin benefit patients in primary CVD prevention. First, Dr. Raymond Oliva.
Good morning, everybody. I am Dr. Raymond Oliva from the Philippine General Hospital. And before I start my talk on statin intolerance, these are my... I apologize. Sorry. Thank you. These are my sins as a medical professor. And the objectives really of this talk is to look into what statin intolerance is, what are the risks and the symptoms, and then the prevalence, and identify the adverse events of statin intolerance, determine treatment options. What if your patients experience, chest myalgia or increases in the ALT/AST? What would you do? And then eventually define a unified definition of what is statin intolerance. Because if you look at clinical trials, statin intolerance is defined in different ways. So the National Lipid Association defined statin intolerance, which I will present later. We all know that statins are the most commonly prescribed drugs in clinical practice. They are usually well tolerated and effectively prevent cardiovascular events. We all know that. We give it to patients with primary and even and most especially for secondary prevention. However, statin toxicity became a general public interest in 2001 when cerevastatin was withdrawn from the market with 52 deaths from rhabdomyolysis, although it wasn't observed in clinical trials. These side effects, unfortunately, impair the quality of life, and they can limit effective treatment of patients at risk or with cardiovascular disease. If you look at the use of statins all over the world, in Denmark, for example, there's an increasing prevalence of the use of statin intolerance over the years. However, there's also an increasing trend of discontinuation of treatment. And if you look at another cohort in the US, the reason that 60% of patients who stop statins, the number one reason is really muscular symptoms. 60% of patients who stopped statin use had muscle symptoms as the reason why they stopped the medication. And if you looking at the big picture, with patients who are statin intolerant, 5.8 million patients have experienced or are experiencing statin intolerance. Even if that's a large number, it's still if you look at the prevalence of statin intolerance, it's very small, 10 to 15% based on the clinical trials. So it's still quite a small number, but then it's there. Patients will experience the side effects of your statin treatment. Why is this very important? To identify and note statin intolerance. Because in patients who stop the statin treatment, because of statin intolerance, there is an increased risk of cardiovascular events in these types of patients. 1.65 patients had statin intolerance based on this cohort, and 36% of the statin intolerant patients who stopped the statins had 36% higher recurrence of MI, 43% higher cardiovascular diseases. There's a low decrease in the all-cause mortality because it's just a 3-year trial. We know that because of the cardiovascular legacy of the statin use, then it has lower rate of all-cause mortality. And even if you look up the sub-analysis of these types of in this cohort, there is an increased risk of cardiovascular disease if you stop the statin treatment. That's why it's very important to know, to identify, and to treat properly patients who have this side effects of the statin. And what are the potential side effects of statins? Statin intolerance is basically a general term looking at adverse events of the statin use. And there are 3 good supportive evidence of statin intolerance or statin side effects. Basically, myopathy, which we see that in a lot of patients. The hepatotoxicity or increases in your transaminases. And right now, there's a big issue on the use of statin with new onset diabetes mellitus, which I will discuss because due to the limitation of time, I'll discuss 3 of this adverse events. And there's other side effects of your statins, which with little or no supportive evidence. What are the factors affecting statin intolerance? There are endogenous and exogenous factors. Advanced age, the elderly patients, because of the changes in the pharmacokinetic, pharmacodynamic properties of the statins may lead to increases in the statin intolerance. Female sex, Asian ethnicity. If you look at comparing Caucasians and Asians appear to have a higher prevalence of statin intolerance because of genetic factors. We tend to have slow metabolizers in the use of statins, especially with your CYP gene, and because we're smaller than the Caucasians. There's other factors such as pre-existing neuromuscular condition, known history of myopathy, pre-existing liver disease may lead to elevations of your ALT, AST, pre-existing untreated hypothyroidism. They say that hypothyroidism lowers the bioavailability of your statins, leading to causes of statin intolerance as well, and certain rare polymorphisms. Exogenous risk factors include high-dose statin therapy, excessive alcohol intake, drug interactions, which leads to affects your CYP3A4 gene, and metabolizing this, lowering the metabolism of your statins, leading to a statin intolerance, excessive exercise, and excessive grapefruit juice intake. And if you look at the system-based adverse events of statins, you see that a lot of them are really muscular. So a lot of system adverse events are more on the muscular system, but then they also affect other systems in the body as well. So let's go to statin-associated muscle symptoms. This is the most common side effect, and the several definitions are given to these conditions, such as statin-associated myalgia, statin-induced myalgia, or statin-related myalgia or myopathy. If you look at the European Atherosclerotic Society, they tend to shy away with the term statin intolerance because statin intolerance, as what I said, is a general term. They wanted to focus more on the myopathy since it's the most common side effect of your statins. And clinical features include symptoms of muscle aches or myalgia, weakness, stiffness, and cramps. If you look at the definition of statin-induced myalgia or muscle symptoms based on the different guideline formations, this is seen in the 2015 Philippine CPG guidelines where we defined the different statin-associated muscle symptoms. Myalgia is defined as focal or diffuse muscle aches or weakness with normal creatinine kinase. Myopathy, any disease of muscle, but then there's an elevation of your creatinine kinase more than 10 times upper limit of normal. Myositis is muscle pain with CK elevation. And rhabdomyolysis, which is a severe cause of statin-induced myalgia, is a severe muscle damage with damage to another organ, such as your kidneys, and a creatinine kinase elevations of more than 10 times upper limit of normal. But in the US FDA, they defined it as a creatinine kinase more than 50 times the upper limit of normal, plus organ damage. So basically, clinical rhabdomyolysis is defined as severe myonecrosis with myoglobinuria or acute renal failure, with an increase of your creatinine about more than 0.5 milligrams per deciliter, and is the more aggressive and severe form of muscle injury, resulting in severe skeletal muscle injury, lysis, and excretion of dark brown urine. It has an approximately 10% of death due to hyperkalemia-induced arrhythmias or DIC. And then this is the definition of statin-associated muscle symptoms based on the European Atherosclerotic Society, which is basically similar to what we presented earlier. What are the risk factors associated with muscle pain in patients with taking high-dose statins? Basically, if you look at here, you have history of muscle pain with another lipid-lowering treatment, unexplained cramping, history of elevated CK, and the type of statins actually, simvastatin has a higher incidence of muscle pain as well. And then if you look at different statins, basically the lipophilic type of statins have the higher incidences of muscular pain, such as your simvastatin and your atorvastatin. If you look at molecular mechanisms of statin-induced myalgia, it's just a lot of clinical hypotheses. There's no defined cause of statin-induced myopathy, but then there are several hypotheses concerning the myalgia. Basically, you can break it down into two: by increasing bioavailability of your statins, including defects in myocyte duplication, autoimmune reactions such as anti-HMG-CoA reductase. There's vitamin D deficiency. As they say, some patients who have statin-induced myalgia may be vitamin D deficient, and myocyte membrane instability and disruption. And of course, the second mechanism is genetic, with mitochondrial dysfunction, decreases in the mevalonate pathways products, ubiquitin, coenzyme Q, alteration in gene expression, leading to apoptosis and protein degradation, leading to your statin-induced myalgia. And then, of course, the molecular structure of your statin can also cause statin-induced myopathy. The more lipophilic, the more synthetic, and the more potent your drugs are, they tend to cause more statin-causing myalgia. So lovastatin is actually credited to be the most lipophilic and the most number of statin-induced myopathy. Simvastatin and atorvastatin. And fluvastatin, which is hydrophilic, may have the lowest risk. The lipophilic statins tend to cross the skeletal membrane, leading to, as here, it can cause such as your mitochondrial DNA in the skeletal muscles, leading to injuries, increasing intracellular calcium, leading to statin-induced myopathy. So that's the molecular mechanism of your statin-induced myopathy. And if you look at the STOMP trial, with using high-dose atorvastatin, there is an elevation of your creatinine kinase and increasing the statin-induced the statin symptoms if you use a high dose of your atorvastatin compared to placebo. But if you look at that clinical trial as well, there is no increase in the exercise function of the patient. So even if there is an elevation of creatinine kinase and there's some symptoms caused by the atorvastatin, it didn't stop the patient to exercise. So that's the findings in the STOMP trial. So the 2015 CPG guidelines in the Philippines proposed this algorithm in how to treat your patient with statin-induced myalgia. So if we go at one by one, patients presenting with myalgia, with myalgia while on statin treatment, check the creatinine kinase of your patient. If it's elevated more than 5 times the upper limit of normal, ask the patient, can the patient tolerate myalgia? If yes, continue statins, but may reduce the dose, and then use symptoms as guide to dose titration. If the patient cannot tolerate myalgia, is there organ damage? Check for kidney damage as well. If it's yes, as an elevation of 0.5 milligrams per deciliter in your creatinine, then it's rhabdomyolysis, discontinue your treatment. If it's not, discuss importance of discontinuation of statin treatment as I presented later. If you discontinue your statins, there's increased risk of MI and cardiovascular disease. Once symptoms disappear, may resume the statin at a lower dose or use a different statin. If you're using a lipophilic statin, then may use a hydrophilic type of statin. Is there recurrence of symptoms? If there's none, continue your low-dose statin, but if there's recurrence of the symptoms, consider the following. Combination therapy with ezetimibe plus low-dose statin, or you can use a low-dose rosuvastatin, or alternate or weekly dosing. There are clinical trials dosing your Rosuva or Atorva weekly or thrice weekly, and it showed that there is reduction of lipid LDL-C as well. Not as good as if you dose it daily, but then there is reduction of your LDL cholesterol as well. This just came out recently, and this may help you look into the statin associated myalgia. There's a validated questionnaire that just came out 2017, and it came from a New York University in the US, and they came up with this one, your statin associated muscle symptoms clinical index. And it's actually a questionnaire you can give to your patients, or you can administer in your clinic. And if there's a scoring system as well. Well, hopefully this will entail us Filipinos or Philippine doctors to use this questionnaire and validate it as well for our Filipino patients. And it's very helpful for identifying who the real patients who have statin myalgia as well. What about the use of ezetimibe? So there's a clinical trial using ezetimibe plus fluvastatin XL on statin intolerant patients, and the combination of fluvastatin XL plus ezetimibe actually lowers your LDL cholesterol as well. And there's decrease in statin-induced myalgia with patients on fluvastatin low dose and ezetimibe. What about vitamin D supplementation? Can we give that to our patients? There is a clinical trial. I'm looking at patients who are vitamin D deficient and giving them vitamin D supplementation to reduce statin-induced myalgia. The results are very, very promising. Vitamin D therapy, about 50,000 to 100,000 IU per week, was safe and effective when given for 12 months to reverse statin intolerance in patients with vitamin D deficiency. As they say, high levels of vitamin D is actually protective against statin-induced myalgia. However, it's a matter of debate whether vitamin D insufficiency potentiates statin-induced myalgia or statins contribute to vitamin D deficiency. And looking at clinical trials as well, atorvastatin actually increases vitamin D levels. So probably it's a vitamin D insufficiency that potentiates statin-induced myalgia. So you may want to screen patients who have statin-induced myalgia with vitamin D, but I'm not sure if all centers have it as well. How about CoQ10? Decreases in CoQ10 may induce statin-induced myalgia, but there's a big clinical trial that says no, it's not. It doesn't really help as much as possible. And the use of fibrates, niacins, and fish oils, you may want to think it over. Niacin, fish oils fail to reduce LDL-C significantly. Niacin has not been proven to reduce ASCVD. Gemfibrocil may be, but then drug-drug interaction as well can come into picture because gemfibrocil affects your CYP3A4. Fenofibrate may be given if you don't have any more, don't have any more options. How about PCSK9? You know, these are their new drugs for statin, reducing LDL in secondary prevention. PCSK9 is proprotein convertase subtilisin kexin type 9, and it's a monoclonal antibody, and they were given to patients who are statin intolerant. The problem with the clinical trials with PCSK9 is the definition of what and who is statin intolerant. We can talk about it, but then looking at the patient population, they may or may not be the true statin intolerant patients. But in this clinical trial, when compared to ezetimibe, there is reduction of LDL-C by 59% with the use of PCSK9 compared to your ezetimibe alone, and even the recurrence of statin intolerance is lower in PCSK9 treated patients compared to ezetimibe, or even in patients who have only atorvastatin as treatment. And of course, you can do this as last resort. Unfortunately, we don't have LDL apheresis in the Philippines, sort of a dialysis for lipids. This can be done to patients who are really statin intolerant, who have elevated LDL-C, despite the treatment of ezetimibe or lowering and all those, and even for PCSK9, you can actually do that. How about hepatotoxicity? The use of statins with liver disease has been the forbidden fruit in lipidology for at least 2 decades, and it was believed that statins are hepatotoxic. And there is actually a slight asymptomatic elevation of your transaminases is one of the more common ones, and you see that you have an elevation of more than 3 times upper limit of normal in your aminotransferases. And the prevalence, unfortunately, is less than 3%. So it's a very small number of patients who have elevations of your transaminases. And looking at cohorts and registries, the rise of transaminases is very rare, but can also, unfortunately, be very severe. And severe drug-induced liver injury was reported in 1.2 per 100,000 statin users, with most experiencing liver injury 3 to 4 months after starting therapy. And the elevation of aminotransferases usually returns to normal after a dose reduction without the need for statin discontinuation. And in some, you can actually resume the initial dose after 2 to 4 weeks. And these are the drugs that can lead to more cases of statin-induced hepatotoxicity. And the molecular mechanism is, I'll show you that same slide, but then if you look at the box ones, these are the more common causes of statin-induced hepatotoxicity. The proposed mechanism of this is the induction of caspase activity, triggering of apoptosis, and reduction of CoQ10 and generation of free radicals when you give statins. However, it's still not clear whether and how statins cause any kind of significant liver injury or even liver failure. In the STOMP trial with atorvastatin, there is an elevation of ALTs, and the atorvastatin increased average of ALT values of 15.7 by plus or minus 27.4, which is statistically significant, and was mostly associated with cholestatic liver injury. In the 2015 clinical practice guidelines, we also give this algorithm for statin-induced hepatic enzyme elevations. Patients with elevated ALT or AST while on statin therapy, if your levels are less than 3 times upper limit of normal, just continue your statin. Check for other causes. Could be hepatitis, could be other causes, drug-induced, whatever. But if your transaminases are more than 3 times the upper limit of normal, stop the statin. And individuals with very high risk for CVD may use other non-statin treatment to lower LDL-C while off statins. Recheck ALT, AST after 2 weeks. If still elevated but not 3 times the upper limit of normal, resume statin at a lower dose or start with another statin. If elevated more than 3 times the upper limit of normal, consider other causes of injury such as viral hep, drug-induced liver injury, or alcohol-induced liver injury. And then re-challenge the same statin with lower dose or other statin with different metabolism. If very high-risk individuals may use non-statin therapy such as ezetimibe or fibrates on top of a low-dose statin to lower your LDL-C. Despite the small risk of this statin causing hepatic injury, statins are considered safe to use in patients with stable chronic liver. It's recommended that frequent ALT/AST monitoring in patients with CLD every 3 months, every month during the first 3 months of therapy and 4 times per year thereafter. With regard to patients who have hepatitis B, hepatitis C, and primary biliary cirrhosis, there are common benefits related to statin therapy in high-risk patients. Statins also confer a more efficient treatment of viral hepatitis and is related with a reduced risk of cirrhosis and HCC. In patients with NAFLD, statin treatment is safe and contributes to the resolution of NAFLD and substantially reduce cardiovascular disease risk to a higher level. So if your patients have mild fatty liver, then you can also just continue your statin as it's very effective in reducing, and it's safe actually. So the last one is the new onset diabetes. It's a very, very tricky and very controversial issue for statin use, and this has been a debate regarding the clinical implications of this phenomenon, whether and when we could start treatment, in what groups we should continue, stop it, or reduce the statin dose, and which groups of patients are at high risk of new onset diabetes. And this is the reason why there is a new onset diabetes. There's decrease in CoQ10 leading to insulin secretion. There's the elevation of your LDL-C is an inflammatory leading to beta cell apoptosis, and decreasing isoproteinoids reduces GLUT4 downregulation leading to decrease in glucose uptake, actually increasing insulin resistance to your to your patients. And in a large meta-analysis, statin therapy was associated with 9% increased risk for incidental type 2 diabetes mellitus. And in Jupiter trial, the presence of a family history of diabetes, endored-impaired IFG or HbA1c put patients at a higher risk for new onset diabetes. And it's not just seen in rosuvastatin, but it's all the classes of statin. So it's basically a class effect looking at this meta-analysis. So even simvastatin, atorvastatin can lead to new onset diabetes. And putting it together in one meta-analysis, so any statin can lead to new onset diabetes. The question is, because of that knowledge of statins causing diabetes, should we stop statins? Statins have been associated with a small but statistically significant risk of new onset diabetes. Patients with risk factors for developing diabetes mellitus may be at higher risk. However, the benefit will always outweigh the risk. So there is a need for careful risk stratification for patients, and definitely you need to start their patients with statins as well. And these are the other statin-related side effects for, aside from those 3 that I mentioned. It's a very, very small number. It affects about less than 1 in 100 people. But then these side effects might reduce the quality of life of your patient. So it's very, very important for us to know the side effects of your statins. So lastly, how do you really define statin intolerance? There is currently no widely accepted definition of statin intolerance, and there is a need to define what really is statin intolerance. So the NLA in 2015 defined statin intolerance So it's the inability to tolerate at least 2 different statins. One statin at the lowest dose, so that's Rosuva 5, Atorva 10, Simva 10, Luva 20, Brava 20, Fluva 40, and Pita 2 milligrams. And the other statin at any dose. There's intolerance associated with confirmed intolerable statin-related adverse effects or significant biomarker abnormality, such as CK and your ALT/AST. Symptom or biomarker changes, resolution or significant improvement upon dose decrease or discontinuation, and the symptoms or biomarker changes not attributable to established predispositions such as drug-drug interactions and recognized conditions increasing the risk of statin intolerance. So this is the definition of statin intolerance. To end, statins are well tolerated and effectively prevent cardiovascular disease. As physicians should identify what statin intolerance is because it limits effective treatment of patients, and monitoring is necessary in these types of patients as the benefits of statins really outweigh the risk of your statin-induced adverse events. Lastly, we would like to, in behalf of the PLAS, we would like to invite you to the APSAV, the 11th Congress of the Asia Pacific Society of Atherosclerosis and Vascular Diseases in Iloilo next year. And we would like our trainees and even you doctors to submit abstracts for the research contest. So thank you very much.
Morning. Before we start, we are part of the 10-country study. This is looking at familial hypercholesterolemia awareness in Southeast Asia. So this is in keeping with the study that was done by Gerald Watts in Australia. We have been conducting this survey from the past 2 years at PHA. So we have Dr. Ira. She will be distributing some surveys. If you have the time this morning while listening to jot down answers to the survey, walang right or wrong answer. It's just asking about familial hypercholesterolemia and what we know of it. We have the first 10 to submit the survey will get a free booklet on familial hypercholesterolemia from Professor Gerald Watts. So she'll be distributing. We appreciate the time if you guys can submit right after you finish your survey. So this morning, we'll be talking about non-statin therapies for lowering LDL and non-HDL. Which patient, which agent? So let's start. When we get a lipid profile, we look at measured total cholesterol, triglycerides, HDL, and LDL. Ito po alam na natin. Ang maganda ngayon, most of the machines that we have that monitor lipid parameters can actually count the particles. So pagka binigyan kayo ng LDL cholesterol dun sa lipid profile nyo, counted particles na yon. Dati, we used to have calculated LDL cholesterol. This was the Fried-Wald formula. But now we actually have machines that can count these LDL particles. And it's important because we know that international and local guidelines continue to recommend LDL cholesterol as the primary target of therapy and of course statins as the first-line drug. So kung titingnan nyo, kahit na yung ating Philippine guidelines in 2015, ADA 2016, the ACC consensus in 2016, and the European guidelines all target LDL cholesterol. And we know that's important because the risk for coronary heart disease with lower LDL cholesterol correlates in a 1:1 log linear relationship where the lower we push LDL cholesterol, the lower that risk for cardiovascular disease is. And this has been shown whether this is genetically lowered LDL cholesterol or pharmacologically mediated LDL cholesterol. So basta pinagbaba mo yung LDL cholesterol, bababa yung risk for cardiovascular disease. But I want to go beyond LDL cholesterol, and I want you guys to appreciate the role of non-HDL cholesterol. Ano po ba yung non-HDL cholesterol? Non-HDL cholesterol is just taking HDL cholesterol and subtracting the number of HDL cholesterol you have from total cholesterol. Bakit po ba importante yung non-HDL cholesterol na yan? When we take the lipid profile, these are all the lipoproteins that are available in all of us. When you take LDL cholesterol, you're only taking a fraction of all the pro-atherogenic particles we have in the body. So, ito po lahat ng lipoprotein molecules. Pag tinanggal niyo yung HDL cholesterol, ang matitira sa inyo lahat ng pro-atherogenic particles. Ang limitation ng monitoring ng LDL cholesterol lamang sa katawan, hindi natin na monitor yung intermediate density lipoprotein, yung VLDL, yung VLDL remnants, at yung chylomicron remnants. So dahil doon, we're missing out on other pro-atherogenic particles that can actually cause inflammation in the body. And that's the beauty of non-HDL. Non-HDL accounts for all these particles that are just not HDL. And HDL is anti-inflammatory, but everything else is pro-atherogenic and pro-inflammatory. So that non-HDL actually estimates all remaining atherogenic particles. So it takes into account VLDL, IDL, LDL, and lipoprotein little a. So that it is actually a better measure of looking at the remaining pro-atherogenic particles there are. So much so that when they looked at the Framingham study, they found that non-HDL was actually superior to LDL cholesterol in predicting CHD risk. There was a strong positive and graded association between non-HDL cholesterol and risk for coronary heart disease within every level of LDL cholesterol. So it was actually graded as a stronger predictor of CHD. So just so you guys can appreciate it, if you have two patients, case 1 and case 2, when you take a look at the LDL cholesterol of case 1, you'll say that case 1, because he has more LDL cholesterol compared to case 2, is more pro-atherogenic. Ang laki ng LDL cholesterol niya, 145, compared to case 2, 89. But when you consider non-HDL, and you consider all the other pro-atherogenic particles that is not HDL in this particular patient, you'll actually see that case 1 has lesser pro-atherogenic particles than case 2, where the non-HDL of case 2 is 177 compared to 169 of case 1. So this is just appreciating non-HDL. When they did a meta-analysis of LDL cholesterol, non-HDL, and ApoB as markers of cardiovascular risk, over a 10-year period, non-HDL actually showed that computing for it prevented more events than using the LDL target therapy. If you take a look at the relative risk reduction, non-HDL had a higher relative risk reduction compared to LDL cholesterol alone. And so, when we compute for non-HDL, ang computation ng non-HDL madali lang. Kung ano yung LDL cholesterol target nyo, if you add 30 to that cholesterol target, then that is your non-HDL cholesterol. So for example, in high-risk individuals, dapat less than 70 milligrams per deciliter ang LDL cholesterol. If you're looking at non-HDL cholesterol, it's 70 plus 30. So dapat ang non-HDL cholesterol goal niya less than 100. In diabetic low-risk individuals, kung ang LDL cholesterol goal nyo less than 100, ang non-HDL goal ng mga pasyenteng yon, 100 plus 30, dapat less than 130. So madali lang i-compute ang non-HDL cholesterol. So much so that even the 2016 proposal for Asian Lipid Consensus for LDL cholesterol targets is actually considering these non-HDL cholesterol targets. So any LDL cholesterol target plus 30 is your non-HDL target. So, madali lang, di ba, ang non-HDL cholesterol? So when we look at how we treat LDL cholesterol and non-HDL cholesterol, statins and dietary modifications are still cornerstone. But going beyond statin therapy, ano pa ba yung mga options natin for patients who may not have statins as an alternative or have limitations to the amount of statins we can give them? In 2016, the ACC Expert Consensus Decision Pathway came out with their algorithm for non-statin therapy for lipid management, where in patients in the 4-ASCVD risk group, ibig sabihin, kung kinakailangan nitong mga pasyenteng to ang statin therapy, you have to consider these factors to be able to give them non-statin therapies. So, this is adherence and lifestyle. Those patients who are statin intolerant, as Dr. Oliva already pointed out with statin myopathies. We look at control of other risk factors. Of course, we talk to patients about potential benefits, harm, and patient preference, in addition to starting that non-statin therapy. And we have to consider how much more LDL cholesterol reduction we want of these non-statin therapies that we will instigate in our patients. And the optional interventions to consider include ezetimibe, bile acid sequestrants, which aren't available here in the Philippines, PCSK9 inhibitors, which are a new line of treatment that we're very excited to introduce you to. And these other agents, mipomersen, lomitapib, and LDL apheresis, which is a process that actually removes LDL cholesterol, which I'll talk about a little in passing because mipomersen, lomitapib, and hopefully LDL apheresis, not in the near future yet, but hopefully will become an option for us here in the Philippines. So let's begin with ezetimibe. So we know about ezetimibe, it's locally available. It's a cholesterol absorption inhibitor, and the mechanism of action is that it blocks the Niemann intestines. So by blocking that Niemann-Pick C1-like-1 receptor, cholesterol absorption is decreased. When cholesterol absorption is decreased, the liver senses that there's little cholesterol, so it upregulates its LDL receptors, and by virtue of that, LDL cholesterol is decreased. When we look at the ezetimibe effect on LDL cholesterol, we see about a 15 to 25% reduction in LDL cholesterol levels. And the clinical trial that translated ezetimibe effects into outcomes was the Improve It trial. So this was a randomized post-ACS clinical trial where patients post-acute coronary syndrome within 10 days of stabilization were recruited. Their LDL cholesterol levels had to be less than 125 milligrams per deciliter or less than 100 milligrams per deciliter if on prior lipid-lowering therapy. They were randomized to simvastatin, 40 milligrams, or simvastatin 40 plus ezetimibe 10 milligrams. And they wanted to see how significant that reduction of LDL cholesterol was. And as you can see, that reduction was sustained over time. when we look at the amount of LDL cholesterol lowering that was given by the Improve It trial, we actually went down to about 50 milligrams per deciliter. This was one of the lowest statin-reported LDL cholesterol lowering with a combination of ezetimibe. And you can see that LDL cholesterol reduction was sustained over time. But did it translate into outcomes? There was actually a statistically significant reduction in primary endpoints. And this translated to a number needed to treat of 50. That means if you treat 50 patients with a combination, you actually get that primary endpoint. So, on top of statin therapy, a non-statin therapy, ezetimibe, showed an improvement in outcomes. So that's the first non-statin therapy. The second non-statin therapy we'll be discussing is PCSK9 inhibition. Ano po ba yung PCSK9 inhibition? So, when we talk about PCSK9, first we have to be able to appreciate LDL receptors. Yung LDL receptors po, it's found on the surface of hepatocytes. And the purpose of that LDL receptor is it binds to LDL cholesterol. So, the hepatocyte makes LDL receptors. These LDL receptors are available so that they can bind to LDL cholesterol. When LDL cholesterol binds to LDL receptors, they get absorbed into clathrin-coated vesicles, and the LDL receptor is degraded in the hepatocyte. That LDL cholesterol is degraded in the hepatocyte. The LDL receptor is allowed to get recycled and goes back to the surface. So yan po ang normal pathway ng LDL receptor. Nire-recycle siya at binabalik siya dun sa surface. So that the more LDL receptors you have, the more binding it has to LDL cholesterol. The lesser LDL cholesterol you will have available in the body because it's binding to the LDL receptor. Ano ngayon mangyayari pagka may PCSK9 ka? So pag may PCSK9 ka, ang ginagawa ni PCSK9, kumakabit siya ngayon dyan sa LDL receptor. Pag kumabit si PCSK9 sa LDL receptor, may signal na yung LDL receptor na hindi na siya babalik sa surface. Hindi na siya pwedeng i-recycle. Kasi basta kumabit sa kanya si PCSK9, ang signal na yan, i-degrade na yung LDL receptor. So there's no recycling once you have PCSK9 attaching to that LDL receptor. So, kung si LDL receptor laging nadidegrade, hindi na siya makakabalik sa surface. So, nababawasan ngayon yung number of LDL receptors in the surface. Pag nabawasan yung LDL receptor sa surface, mas konti na yung nakakabind sa LDL cholesterol, tumataas yung total LDL cholesterol sa katawan. And so what they developed was a molecule that inhibits PCSK9 para mawala yung signal na nagbibigay sa LDL receptor na dapat ma-degrade siya. Instead, kung in-inhibit natin si PCSK9, what happens is the LDL receptors can keep getting recycled, going back to the surface so that it can bind to LDL cholesterol, in effect, lowering LDL cholesterol. So, clear po ba yon sa PCSK9 inhibition? So, PCSK9 binds to LDL receptor, it prevents recycling, so nadidegrade yung LDL receptor. So pag in-inhibit natin si PCSK9, si LDL receptor pwedeng bumalik sa surface para dumikit yung LDL cholesterol, in effect, lowering LDL cholesterol. So that is what PCSK9 inhibition is. Is that clear? All right. So there are two PCSK9 inhibitors that are in development. There were actually three, but that has actually been resolved. So Pfizer actually pulled out their PCSK9 inhibitor, and now we have two. The first PCSK9 inhibitor is evolocumab. So these are the evolocumab trials that have been carried out. These are the patient populations where evolocumab has been given. Yung evolocumab po, it is given 140 milligrams twice weekly or every 2 weeks, or 420 milligrams every month. So the types of patients they looked at were those with very high LDL cholesterol. These are our familial hypercholesterolemic patients, or patients who were very high risk, still with LDL cholesterol not reaching their goal. So these were given at particular times, and what they found was that evolocumab was capable of lowering LDL cholesterol by more than 50%. The doses of 140 milligrams biweekly and 420 milligrams monthly were equivalent. It didn't produce side effects in statin-intolerant patients. As Dr. Oliva mentioned, this has become a limitation, and the effects actually extend to 1 year. So zeroing in on one clinical trial, the Laplace-2, we found that the non-HDL reduction was very significant with evolocumab compared to ezetimibe as well as placebo. So you can see very significant reductions in non-HDL cholesterol over just LDL cholesterol. And that primary endpoint in Gauss-2 was actually sustained when they looked at LDL cholesterol reductions. Pero lahat nitong mga clinical trials na pinakita ko so far, LDL lowering pa lang. Wala pa tayo sa outcomes trials, which we'll talk about in a while. The second PCSK9 inhibitor is alirocumab. So alirocumab, the difference is this one had a 75 milligram dose. So this 75 milligram dose was given every 2 weeks. You can actually up-titrate to the 150 milligram dose. So ito po lahat injection, evolocumab and alirocumab. And these were the patient populations. Patients who were statin intolerant, those who had prior CVD, goals still not met with LDL cholesterol more than 70 or more than 100, and of course, patients with familial hypercholesterolemia. And when they looked at the LDL cholesterol lowering, you see very significant LDL cholesterol lowering, which was sustained over time. So this was Odyssey Combo 1. So this was the LDL cholesterol reduction, 48%, maintained throughout time. And the longest was the Odyssey long-term, which actually extended up to 78 weeks. So when we look at the efficacy for PCSK9 inhibitors, we see very significant reductions of LDL cholesterol, more than 50%, on top of statin therapy. And you have non-HDL cholesterol lowering that is very significant. But you know, when we talk about LDL cholesterol lowering, it doesn't really matter if you lower LDL cholesterol. What matters is that it translates into outcome. Pinabaan ko nga yung LDL cholesterol, pero nabawasan ba yung stroke? Nabawasan ba yung risk for cardiovascular death? And so they looked at CV events in long-term PCSK9 trials. And in the Odyssey long-term, in Osler 1 and Osler 2, they found that when we reduce LDL cholesterol to about 50% on top of statin therapy, nagtatranslate pala into outcomes. Meron palang reduction in CV mortality and morbidity. And so this spurred on other clinical trials that look particularly at outcomes. So these were two clinical trials. This is the Fourier and the Odyssey outcomes. The Fourier outcomes trial was supposed to complete October 2017. but because it had such significant results, they actually pre-terminated the study, and it was published May 2017. So I'll just give you an overview, because today we have a symposia which will actually talk particularly about the Fourier trial as well as the outcome. So Dr. C will be talking about it today. So Fourier was actually 27,500 patients with clinically evident cardiovascular disease. They had prior MI, stroke, or PAD. These patients were 40 to 85 years with more than one other high-risk features. And these patients were randomized to either evolocumab every 2 weeks or monthly, or placebo, and they were followed up over 4 to 5 years. So as I mentioned, these patients were actually just followed. The trial ran for 4 years because of the benefit that was seen. These are the LDL cholesterol levels that were reached. As you can see, very significant reduction in LDL cholesterol that was sustained over the trial. In those patients with LDL cholesterol less than 70 milligrams per deciliter, evolocumab reduction was 87%. In those less than 40, 67%, and in those less than 25, 42%. And when they looked at the primary endpoint, so these are the outcomes: cardiovascular death, MI, stroke, hospitalization for unstable angina, or coronary revascularization, there was a significant reduction in outcomes, where the number needed to treat was 74. So in the Fourier conclusions, when added to statin therapy, evolocumab lowered LDL cholesterol levels by 59% compared to baseline. From baseline compared to placebo, from a median of 92 milligrams per deciliter to 30 milligrams per deciliter. There was a decreased risk of primary composite endpoints by 15% and secondary endpoints by 20%. The magnitude of risk reduction was shown to increase over time. So similar to statin therapy, where the longer you keep patients on statin therapy, the bigger the magnitude of reduction of cardiovascular morbidity and mortality. There was no effect of additional LDL cholesterol lowering on CV death or all-cause mortality, and injection site reactions were significantly higher, of course, in the evolocumab group. But aside from this, there were other parameters that are coming out that seem to be improved by PCSK9 inhibition. And the latest was the GLAGOV trial, which was also discussed previously. The GLAGOV trial actually looked at 968 patients with symptomatic coronary artery disease with coronary angiography findings of 20 to 50% stenosis in one lesion. They optimized the statin dose for 4 weeks, and then these patients were given evolocumab. And what did they find? They found that in those patients who were on evolocumab, there was a significant change in percent atheroma volume and total atheroma volume. What was very striking was, not only was there a greater number of patients with regression of plaque compared to those who were on placebo, but there was also a lesser number of patients whose plaques progressed. So, ibig sabihin, mas konti na nga po, mas marami na nga po yung nag-regress yung plaque, mas konti pa yung mga pasyente na lumaki yung plaque when they looked at these patients and they followed them over time. There was even an exploratory subgroup. These were patients whose LDL cholesterol was already less than 70 milligrams per deciliter. And similarly, they found that even those in patients with LDL cholesterol less than 70, the change in percent atheroma volume was significant, and the percentage of regressors was very significant in the combination of statin and PCSK9 inhibition. So of course, the issue is always going to be, Paano yung safety? Ano ba yung mga side effects na maaring makita natin pag masyadong mababa yung LDL cholesterol? So we always worry about neurocognitive defects. But they found that it was not statistically significant between the two. And remember, we had a subgroup that had an LDL cholesterol that was less than 70 milligrams per deciliter. So we're talking about very low numbers here. And there was no side effect of neurocognitive deterioration, new onset diabetes, or myalgias. So the third agent we're going to be talking about are PCSK9 synthesis RNA inhibitors. Ano naman yung PCSK9 RNA inhibitors? So sabi natin, yung PCSK9, pagka nag-bind siya sa LDL receptor, dinedegrade siya, di ba? So si LDL, hindi na pwedeng bumalik sa surface. So sabi nila, kesa i-inhibit natin yung PCSK9, huwag na tayong mag-produce ng PCSK9 para wala nang signal sa katawan na magbabind sa LDL receptor para i-degrade yung LDL receptor. Kesa i-inhibit natin yung PCSK9 sa katawan, gumawa tayo ng mRNA splicer. It will slice the mRNA para hindi siya makaproduce ng PCSK9. So, PCSK9 RNA inhibitor, inclisiran, inhibits PCSK9 synthesis. Bakit sila gumawa nun? Well, sabi nila, yung monoclonal antibodies, PCSK9 inhibitors, kailangan mo i-inject every 2 weeks or every month. So, ibig sabihin, in a year, you have to inject 12 times or 24 times kung every 2 weeks. So, sabi nila, baka naman pwede tayong wag nang gumawa ng PCSK9 sa katawan para once a year na lamang or 3 times a year na lamang yung injection. And so, they came up with the Orion trial. So, this was a phase 1, 300 milligram sub-Q inclisiran lowering for LDL cholesterol. And they found that it lowers it by 50% for about 4 to 6 months. Ibig sabihin, kalahati ng taon, yung LDL cholesterol mo nalo-lower to about 50%. So as I mentioned, with these mRNA-induced slicing complexes, it cleaves that PCSK9, causing degradation of mRNA, so you don't produce PCSK9 anymore. And what did they find? They found that there was a significant reduction in LDL cholesterol whether you gave it once or twice. So this was the dosage from first injection. And this is the non-HDL cholesterol lowering. There was a 42% reduction with a 500 milligram dose and a 30% reduction with a 100 milligram dose. And when they extended it to 180 days, they found that that reduction in LDL cholesterol was sustained over the 180 days. So, for the next 6 months, hindi mo na kailangan mag-inject kasi na-lower na natin yung LDL cholesterol mo from 30 to 50%. So, that's for the PCSK9 inhibitors and the RNA inhibitors for PCSK9. The next 2 agents I'll talk to you about are very far from coming to Asia. We don't know if there will be a population that will benefit from it. The first one is lumitapide, which is a microsomal triglyceride transfer protein inhibitor. And what it does is it prevents incorporation of ApoB into lipids. So it's US FDA approved. The oral dose is 5, titration to 10 milligrams. In the United States, only lipidologists can give it, and it's under a database. So, hindi lahat pwedeng magbigay nito. We don't know if this will eventually be available in the Philippines, but the indication is for heterozygous and homozygous familial hypercholesterolemia. The second drug that will unlikely come to the Philippines is oligonucleotide inhibitor of ApoB100 synthesis. This is mipomersen. It is also an injectable. It's used actually now in the United States for patients who are undergoing LDL apheresis. So, iba naman po yung patient population. As I mentioned, these last two drugs probably will not be available in Asia anytime in the near future, as opposed to the PCSK9 inhibitors and the PCSK9 RNA inhibitor. So, ano po ba tong LDL apheresis na to? So, actually, this liposorber and the health system, they're excited to come to Southeast Asia. Malaysia, Taiwan, and Japan already have it. We're hoping the Philippines will be their next target. What is it? It's actually taking LDL and dialyzing it out of your system. So we make patients sit down for 4 hours. We take their blood. We remove the LDL cholesterol from their blood, and then we return the blood to them without LDL cholesterol. The amount of times we do LDL apheresis is anywhere from every 2 weeks or every 4 weeks. So we've had homozygotes, mga bata pa po, 4 na oras silang nakaupo doon, and then every 2 weeks they come back. So this one is safe even for pregnant women. So we used to apheres pregnant women who had very high LDL cholesterols who were at high risk. But of course, these are homozygous familial hypercholesterolemia. So ang indication for LDL apheresis are FH patients. Kaya po kami nagsasurvey at kaya po kami naghahanap ng mga pasyente with familial hypercholesterolemia so that we know what our indication is in the Philippines. If we look for patients with familial hypercholesterolemia, then it paves the way for therapies that we don't know are available to us but can be available for us if we know that the indication is there. So, the systematic review of LDL apheresis for patients with familial hypercholesterolemia, you can see very significant reductions po in LDL cholesterol. 218, 140, 238. So, ganyang kalaki po yung napapababaan namin with LDL cholesterol, with LDL apheresis. So, because my time is almost up, and we are talking about which types of patients these non-statin therapies are indicated for. I want you to meet Yuki. She's 36 years old, a teacher and an artist, active in her local art community, doesn't really like to exercise. She was recently started on high-intensity statin therapy for elevated LDL cholesterol levels. But she's not really responding well. And her doctor concluded that she's unable to tolerate high-intensity statin therapy. So for Yuki, which of the following should the doctor recommend? Stop statin altogether, use the maximum tolerated statin intensity, use a non-statin drug, or use the maximum tolerated statin intensity and a non-statin drug. So because Yuki is unable to tolerate high-intensity statin therapy, we should use maximum tolerated statin intensity. And once maximum tolerated statin intensity has been achieved, addition of a non-statin drug may be considered to further lower LDL cholesterol. Ito naman po si Feng. Si Feng, pumasok siya sa LDL cholesterol of more than 190 milligrams per deciliter. So may familial hypercholesterolemia si Feng. Pinrescribe na po siya ng high-intensity statin therapy. Pero kung hindi niya na-reach yung target niya with statin therapy, dahil naka-high-intensity statin therapy na siya, ano pa po ba ang option natin? Use maximum tolerated statin therapy, add a non-statin drug, or both? Siyempre, both. Kasi primarily, statin therapy should be maximized before we go to non-statin therapy. And last patient is Mira. Mira is 24 years old. She's an aspiring model, has a busy social life, is physically active, and eats a meat-free diet. She has no major health problems in the past, but both parents were significant to have elevated LDL cholesterol levels. Recently, may napansin po siyang mga fatty skin deposits on her elbows. Napansin din niya na yung legs niya medyo nagka-cramp na po pagka-shopping siya with friends and hindi na nag-heal yung sores niya on her toes. After several weeks, she becomes very concerned and visits her doctor. Ano po yung mga small fatty skin deposits on her elbows? Does anyone know? Beautiful, Santos. So she has familial hypercholesterolemia and she has the physical stigmata of FH. She has LDL cholesterol deposits in her elbow tendons. These are tendon Santos. And when she noticed her legs start to cramp when she's shopping with friends, what do you think she's already developed? Peripheral arterial disease. So this is early onset coronary heart disease risk equivalent. So Mira has symptomatic familial hypercholesterolemia. So she goes to her doctor based on her concerns and family history. Mira's doctor orders a lipid panel and her LDL cholesterol, not surprisingly, is more than 190 milligrams per deciliter at 230. So her doctor diagnoses FH, orders a genetic test. Unfortunately, in the Philippines, wala pa tayong genetic testing, pero meron po tayong clinical practice guidelines na merong checklist for Dutch Lipid Network criteria para makadiagnose po kayo ng FH kahit walang genetic screening. So, which of the following interventions are likely to achieve the greatest reduction in LDL, ApoB, and total cholesterol for Mira? Rosuvastatin, alirocumab and rosuvastatin, or ezetimibe and alirocumab? May nagsagot po ba ng D? So, the answer is C. And even though ezetimibe can give you additional 18% reduction, please remember that statin therapy is primary. So even with non-statin therapy, you have to give statin therapy a try first. So we do not treat without statin therapy because very robust clinical trial data. We start with statin, you add non-statin therapies if goal is not reached or if patients are statin intolerant. Thank you. So please return your surveys. We would like to invite you to the 2018 APS-AVD Convention in Iloilo City next year.
Good morning. I'm here to talk about risk factor counting in determining patients who are of benefit for statin therapy. So I have basically 15 minutes left for this time. So I have to be quick. So this will be the outline of my lecture. So this particular subject stemmed out from this particular statement of our lipid guideline, which is on non-diabetic primary prevention, no? Which states that for non-diabetic individuals aged 45 years or more with LDL-C of more than or equal to 130 milligrams per DL and 2 or more risk factors without ASCVD, statins are recommended for the prevention of cardiovascular events. So the term here that we will discuss is how did we arrive with the number of 2 or more risk factors. So for sure, most of you in the clinics are encountered with a lot of questions when a patient comes into you without any history of cardiovascular events and is asking for a clearance for work or just a simple checkup. So these are basically questions that come into your mind. How do I identify people who are at increased risk of a cardiovascular event just by looking at the patient's clinical profile? How do I weigh the individual effects of all the causative risk factors when assessing a person's risk? How do I stratify the risk to determine who needs lifestyle advice and who needs additional medical therapy on top of that? And lastly, how do I ensure that I am not over-medicating those persons who are at low risk of an event? So before the guideline came out, there are risk assessment tools that came out, which probably most of you had tried using. And this risk assessment tool really gives us an estimate of the probability that a person will develop cardiovascular disease over a specified amount of time. And it can help us identify who is most likely to benefit from treatment, and can be used to determine who should be offered preventive medical therapy, especially those who are hypertensive and with high lipid levels. No? So how did these guys arrive with such tool or calculator? So I'll give you an example, which was the first calculator to come out in the public or used, which is the Framingham Risk Score. Basically, the Framingham Risk Score was developed from a group of individuals from Massachusetts. No? And when they followed these patients who have no cardiovascular disease from the onset, they pulled data. Then they look at their clinical profile. So this was way back 1950s. No? And when they followed them up, even their offsprings, they arrived with basically point systems for every risk factor that they identified. And for every risk factor that they've identified, they further sort of made greater numbers or scores to make or arrive at a particular risk factor level, no, for our 10-year risk. For example, in this 55-year-old individual, whether this is a male or a female, you would see here that after a BP of 120, then eventually the systolic BP went up to 160, the level of risk increased, whether this is a male or a female patient who is a 55-year-old. But when you put cholesterol on top of that, and later on HDL, then diabetes, cigarette smoking, and LVH by ECG, you would see an incremental increase of estimated 10-year cardiovascular events. No? So with that, it's important that you have a cohort. And in the cohort that I mentioned, there are a lot of cohorts that are around in the world, especially in the European countries and the US. To name a few, you have here the PROCAM, the Interheart, ARIC, and the Cardia study down the line. However, when you look into these different cohorts, there are no large Southeast Asian cohorts that we could apply to validate these risk assessment tools that we have. So what could be the limitation? As I mentioned, they have no Southeast Asian population, and some of these have no variables for putting into place socioeconomic status, and as well, we should place in mind that for every region of the world, they have different lifestyle factors. No? For example, in a Mediterranean country, we cannot compare the lifestyle that they have to us, no? Because they basically have a Mediterranean diet that could vary the risk when we compare this, our cohort or population compared to them. And globally, CVD events differ markedly between populations because of that. And as we have various treatments available that can lower risk, there will be, in fact, temporal changes that can decrease the prevalence of CVD event rates. So we must put that in mind, that these factors or limitation of the risk calculators. So I'll just name a few of these CVD risk preventive or predictive scores and its disadvantages. So for example, the Framingham cohort that I've mentioned, so this basically enrolled 30 to 74-year-old individuals, and they look at the 10-year risk CVD events. However, this is, as I mentioned, based on a large cohort in Massachusetts and does not take into account ethnicity, family history, socioeconomic factors. No? And the score, which is used widely in Europe, only just predicts CV death and does not take into account non-fatal CVD events and may underestimate this risk in patients with diabetes, central obesity, family history of premature CVD, low HDL, which is quite prevalent in our country, or elevated triglyceride. So others, ProCam, because they are Germans, but among this cohort, they have a wide range in terms of the age range. They started enrolling patients from 20 to 75 years, but again, it only estimates risk for fatal or non-fatal MI and acute coronary death, but not stroke. And the Q risk, which is used in UK, they arrived with this calculator using medical records based on their data set. So with that, it's prone to bias and prone to have a lot of incomplete data. So those are disadvantages of this available CVD risk predictive scores. So with that, over time, a lot of, let's say, scientists or PhDs tried to validate these CVD risk scores over this known cohort. So they have three types of validation. First is discrimination. It means ability to distinguish between patients who are at higher risk compared with lower risk. So they use the C statistics or the area under the curve. So if it touches near the 1, then it's an excellent risk score. It could be applied to that particular cohort. It could discriminate which is low or high risk. Next is calibration. It's the ability of a model to predict the absolute level of risk observed, meaning predicted versus observed risk in a particular cohort. And lastly is reclassification. This applies to new possible markers like your HSCRP, BNP, or coronary artery calcium score, which could be new risk markers. And if you apply them on top of the traditional risk factors that we know, could probably reclassify these patients who are from intermediate to high or even low risk. For example, in 2003, the European country developed the score system. So what they did is this Scandinavian region, particularly the Danish, they arbitrarily put them into a high-risk population or high-risk cohort. But when they observed the score and the actual observed risk, no, they saw that they were overestimating the CVD event rate. No? That's why you could see here in this graph that they have the score low risk and the score high risk, which was developed particularly for the Danish cohort or Danish population. And you see here side by side with the UKQ risk and the recently ACCH AHA guideline packet calculator, which came out 2013, right? You would see here overestimation, no, of the calculated risk over the observed risk, no, of any individual, whether you're male or female, whether you're 60 years old or less than 60 years old. And with that, there's a meta-analysis, but actually because of the high heterogeneity of this group, they cannot arrive with sort of a total or summation of all this data that we see. So they just arrive with a forest plot just to see, show to you the different cohorts wherein they applied the Framingham risk score. On top is Framingham coronary heart disease calculator and the Framingham cardiovascular disease calculator. So for areas in Germany and France wherein cardiovascular events were quite low, they saw that they were over-predicting a cardiovascular event in terms of risk, no? When they applied the Framingham. So we have no sort of right to use these calculators because we cannot validate these available calculators because we don't have a Filipino cohort yet. No? But for that, don't be really so down or so low because we, as I'm part of the group, we have this study, the life course study in cardiovascular disease epidemiology, which is a study involving Southeast Asian countries. No? This came about with the officers of the APSAB, no? Which Dr. Loella, Dr. Oliva have invited you to attend next year. And we are part of the group, no? And Dr. C is our primary investigator, and this is our team. And basically, the concept is just copying or replicating what the Framingham study did, no? Looking at healthy individuals, then over time looking at their CV risk factors, psychosocial factors, and also environmental factors. And lastly, genes, no? It's because we also have got their serum and place them in the freezer and later on do a gene analysis of these patients. And after 10 years, look into their cardiovascular events. So these are our inclusion criteria, 20 to 50 years old who don't have any CVD and able to speak Tagalog or English. And exclusion criteria are as follows. No? So the study areas that were included were basically from in Luzon. But the grand scheme when we were starting is to go from Luzon to Mindanao, but it's really a very expensive study to endeavor. So probably the PHA could grant more funding to us, especially the trust now is going into research. No? So we have areas from Metro Manila, Bulacan, Batangas, Quezon, and Rizal. And so far, these are the things that we have done. No? So we have recruited from 2009 to 2011. And after that, we did some retention strategy in between because it's very hard to see patients after 5 years and as our personal experience, having no national ID, it's very hard to find and locate them. No? So when we did our contact tracing, we were so surprised. Some of them have migrated despite that exclusion criteria that we have. No? And right now, we have done a 5-year collection of data, and we are doing data analysis as of now. And we will be presenting this in the UPSAB convention next year, the 5-year follow-up data. And the calculators that we have for 10 years, probably we could validate them probably by 2020. So counting risk factors for now, as I mentioned, could be for the meantime a substitute, no, on top of a CV risk event. And it's easy to do and practical to do, especially in the rural areas. And like the study, the Interheart, no, which looked into number of risk factors. No? In this graph here, you would see that the more risk factors that you have, the more likelihood that you have will be having first MI. No? So that's a striking number of 9 risk factors. No? Mataas na mataas yung odds ratio. And when you identify them, like in this particular trial, ASCOT, 3 or more risk factors, no? 10,000 patients, you would see a significant reduction in their cardiovascular events. So merely by counting risk factors, you could identify these patients. And it's not a new concept. No? You would see here in the old ATP guideline, no? On your right, risk categories, no? They are not using really the calculator. Instead, they're counting numbers of risk factors. No? You would see here the numbers of risk factors as well as their target. No? Same as the National Lipid Association. No? You would see number of risk factors is an option on top of your calculators. No? So going back to that, probably you could really be comfortable in using our guideline because it's not just make up or we did that up. No? And lastly, no, it's this when the guideline came out, this sort of validated our risk factor counting, the HOPE-3 trial. No? So the HOPE-3 trial, these are their inclusion criteria. You would see here the men 55 years or more or 65 years or more for females, that they only counted the number of risk factors, no, which are this following, at least one of them. Then they treat them with rosuvastatin, or if the female is 60 years or more, they just count the number of risk factors. They started then on rosuvastatin. And you would see here the demographic profile of this population in the study. Basically, somewhat reflects Filipinos because you see here, like when we did our initial analysis of the life care, we would see a high elevated waist-hip ratio, a high low HDL, which is seen in Filipino individuals, no? And other risk factors. And when they started these patients on statin, particularly Rosu, you would see that there would be a relative risk reduction of about 25%, no, which started about 5 years, no, after treatment. No? And looking at individual endpoints, stroke showed a statistical significant reduction of 30%, MI by 35%, and coronary revascularization by 37%. So again, be comfortable of using the CPG statement on non-diabetic primary prevention. So for this part of this guideline, you won't see that in the pamphlet, no? But this is the meta-analysis we did, particularly for the non-diabetic population. So for total mortality, when you give statins, it will decrease it by 19%. For CV events, 27%, and stroke, 26%. No? So in conclusion, no? So CBD in most people is the product of several risk factors that may interact to greatly increase risk, and an approach that focuses on only a single risk factor may result in inappropriate management decision. No? So severe risk models are useful to estimate an individual's probability of developing CVD. However, this is still yet to be validated in the Filipino population. So for that, risk factor counting for the meantime is easy and useful in identifying patients who will benefit in statin therapy. And the Philippine guideline on primary prevention serves as a quick reference to us Filipinos in identifying patients who will benefit from statin therapy. And as a parting slide, again, makulit po kami, you should, will advise you or invite you to attend the APS-CVD, and probably as a board of directors sa PLAS, join PLAS right now, no? Be a member, even because right now we don't, wala po kami membership fee. It's for free. But probably in a few years, we will be having lipidology courses, and kung member pong kayo ngayon, you're, sort of, para free from that, might be part of the faculty. So with that, thank you po, and good morning.
The session is ended, and we don't have any time for further questions. But I'd encourage you, for those who have the questionnaire, kindly return it to the front table so we can gather these things. Thank you very much.